Hi everybody, welcome. We are here at 40 Skokie Boulevard in Northbrook, Illinois. I'm Sydney Pearson. I work in the Business Development Department, and it is my honor to introduce Dr. Kim Dennis this morning. Dr. Dennis is the co-founder, CEO, and Chief Medical Officer at SunCloud Health. She is a board-certified psychiatrist who specializes in treating eating disorders, addiction, trauma, and multi-occurring disorders. Dr. Dennis believes in and maintains a holistic perspective in the practice of psychiatry, incorporating biological, psychosocial, and spiritual approaches into nuanced, individualized treatment plans. Dr. Dennis obtained her medical degree from the University of Chicago, Pritzker School of Medicine, and completed her psychiatry residency training at the University of Chicago Hospitals, where she served as chief resident. Dr. Dennis is a clinical assistant professor in the Department of Psychiatry at the University of Illinois at Chicago College of Medicine. It is my honor to welcome Dr. Kim this morning.
Thank you so much. Thank you so much, Sydney. And thank you, everybody who's come this morning. I'm really grateful to share this space with you and honored that you decided to spend time learning on this material. My hope is that we can learn together today. I'm, as Sydney shared, the co-founder of SunCloud Health. I want to thank my SunCloud team here who put this event on and did a lot of the legwork to make this possible today. And I want to thank all of the people who are attending remotely as well. I'm going to try my best to spend at least 10 minutes at the end fielding questions, first from you all in the room and then also from some of the folks who are joining us remotely today. Feel free to stream on in as you come. I'm going to be talking today about GLP medications in disordered eating, and my hope is that we can leave this experience today with a better understanding of the entirety of the evidence and an appreciation for the possibility of personalized, nuanced care for patients who have eating disorders or disordered eating and are either on these meds or considering these meds. Disclosures: I'm a board member at Galen Mental Health, a board member at the Eating Disorder Coalition, and I have privilege, a lot of it. I have white privilege, I have thin-bodied privilege, cis-passing privilege, and it's important for me every single day to acknowledge that. One of the things that we talk a lot about in our field, in the eating disorder field, is bias, and in medicine more broadly. And bias stems from a whole bunch of different places, right? So privilege, and privilege comes from a whole bunch of different places. There's also discipline-specific training. You know, I was trained as a psychiatrist. I look around the room and I know there are people who are trained psychologists and trained dietitians and trained certified addictions counselors. And we all, by virtue of our training, carry some way, shape, or form of bias based on that training to our clinical practice. Professional specialty confers bias, and also lived experience. You know, many of us in the eating disorder world have lived experience. I'm a person with lived experience and long-term recovery from bulimia, food addiction, alcohol use disorder, and trauma. And it's important for me to know that, and to also know that my lived experience is going to be necessarily different than any other person, even if they have the same diagnosis, even if they look like me, because they have a different biology, they've had different life experiences. I think this is especially important when we're talking about people who don't look like us or who have different types of illnesses that fall beyond standard buckets that we find in the DSM-5. So I'll review basic physiology of the medications. I'll talk about implications for patients with eating disorders, review the research, and then spend the last part of the session talking about how to actually navigate discussions with patients in meaningful ways and in non-judgmental, nuanced ways. So what is a GLP? It's glucagon-like peptide 1, and it belongs to a class of medications that are known as incretins. And when we ingest food orally, GLP is something that gets released, and it stimulates insulin. It has many other functions as well, right? So it's secreted in our small intestine and colon. There are other areas of the body that make it as well, but the bulk is there. And the receptors are found all throughout the body on multiple different organs. The pancreas, the stomach, the liver, muscle tissue, adipose tissue, the heart, the brain. And you can see in this slide the many different functions that GLP, naturally occurring GLP and this is similar to the functions that GLP-1 receptor agonist medications have. So slows the gut, which is part of why it increases satiety. It stimulates insulin release from the pancreas, which is why it's beneficial for those folks who have type 2 diabetes. It increases glucose uptake in our muscles and in our adipose tissues. It decreases glucose production from the liver. Again, this is good for glycemic control. It improves cardiac function, right? This is an important, we hear so much of this narrative has been focused on weight loss. And what we don't hear about as much are some of in the eating disorder field, particularly, are some of the other effects, including increased cardiac function and increased cardio protection. And then in the brain, these receptors are found in several different places, one of which is the ventral medial reward circuitry, which you can see on this slide, which starts with the ventral. This is very simplified, starts in the ventral tegmental area. Dopaminergic neurons project to the nucleus accumbens, and that in turn sends projections to many different places, including the limbic lobes, but particularly the prefrontal cortex. And anytime a person engages in anything pleasurable, whether it's eating something that they like, or gambling for some folks, ingesting substances, this reward circuitry lights up and becomes activated. For certain people, depending on their trauma histories, depending on their genetics, depending on their level of exposure to certain substances or certain behaviors, this circuitry becomes sort of on autopilot or is increased in sensitivity than it might be for the next person, right? So when we talk about understanding that my lived experience and even what I experience when I eat, X food might be a very different experience than Shale eating that same food, right? Because Shale's brain is different than my brain. Shale's lived experience is different than my lived experience. When we think about food and what happens, what areas of the brain are activated in response to food, these are the major areas, and these are also areas that contain GLP receptors. So we talked about the reward circuit. The lateral hypothalamus is what regulates hunger and fullness. And then we have the orbital frontal cortex, which is really important because the medial part of that, the part closest to our noses, is very involved in cue saliency. So scanning the environment and what's important to me, or like what's most salient to me in the room. The lateral part of that, more towards our ears, is where our brakes come in. It's the inhibitory center, right? If I am a person that has impairment in this circuit, including the reward circuit, which projects up to the orbitofrontal cortex, my reward saliency is heightened when it comes to certain, whatever that thing is for me. And my brakes are shut off. And that's not conscious, that's not intentional, that's not something that people can control just by thinking about it, no more than I can control my blood sugar by saying like, it feels like my blood sugar is high right now. Like, if I can't think my way out of that. Okay. Can you forward, Thal? Okay. So how about the GLP receptor agonists? It's important to know that these medications are not new. We've heard way more about them in the last 3 years, 5 years, year, than we ever have before. And I've talked about these medications several times over the last 6 months, and every single time I'm adding studies to it because every day there's a new study coming out or a new indication. So this is a very much an evolving piece of medicine right now. So initially they were approved to treat type 2 diabetes, and then later they were approved for weight management. As they've developed more and more and more, starting with our current era of them, when we're talking about semaglutide, Ozempic, Wegovy, Mounjaro, both the glucose lowering effects and the weight loss effects have significantly increased. And I'll show you a slide of that in a bit. So the newer agents carry FDA indications for type 2 diabetes, weight management, and also reduction of cardiovascular risk, which is new for patients who have cardiovascular disease. And that indication was just obtained last month for semaglutide. As we reviewed, these medications have multi-system impact. And we know that the receptors in the brain affect people's experience of eating and decrease reward that is related to eating or hedonic eating. This is a list of approved GLP medications. First one was approved in April of 2005 for type 2 diabetes. Then we moved to liraglutide, which is Victoza. And one of the patterns you'll see as we get closer to the new age meds at the bottom is these medications. So for example, liraglutide is Victoza when used in a certain dose for diabetes. And then in a higher dose, it's known as and branded as and approved for more weight loss. And it's called Saxenda. Right? Same thing as we get down to 2017 when semaglutide comes onto the market. Ozempic is the same thing as Wegovy, just in different doses, right? They're both semaglutide. And patients don't know this, right? Patients, I talk with patients. I think anybody that is practicing right now has somebody on these medications. Right? And I have some long-term outpatients who happen to be on these. And they don't understand that these medications have been around a long time and there's different levels of potency. Right? So the only thing they're being told and the only thing they know is like, well, my doctor said I should be on Mounjaro because it's the best one. Well, what did they say that meant? just that it's the best one, you know? So a big part of my work is, again, trying to give people truly informed consent, right? And that goes both ways, folks. It's not just like we in the eating disorder field know what true informed consent is, and we're going to give it in a biased way that these medications should be demonized, right? There's plenty of concerns and plenty of risks, but there are also some really important benefits, you know. And if I'm bringing my bias to any patient encounter, the patient knows that immediately. They sense that that I have an agenda or an angle, you know. When I do walk into a conversation with an angle or an agenda, I'm explicit about it and transparent about it, you know, and I think patients appreciate that. Anyway, so we get down to the bottom, to Mounjaro or tirzepatide, which is also Zepbound, which is, again, Mounjaro just for weight loss. And this slide shows you a little bit about the indications for these medications. So again, what you'll notice for liraglutide, for semaglutide, and also for tirzepatide, that these medications initially get their type 2 diabetes indication, and then usually higher doses are approved for weight management, right? Same with all of these medications. Tirzepatide, you know, maybe 9 months ago when I first started talking about these medications, was only approved for glycemic control in type 2 diabetes. And then in November of 23, Zepbound, which is the same medication, got an indication for chronic weight management. So important to know there are different potencies, and even for each medication, there are different doses of the medication, right? So when I talk to a patient about what medication to take, we talk about dosing and getting to the dose where they are experiencing the maximum benefits of the medication without incurring much at all in the way of side effects, right? So there's that sweet spot that as psychiatrists we try to get to with our patients. So GLPs by the number. National spending on semaglutide reached $10.7 billion in 2021. And it's higher now, you know. And, you know, myself and our other like medication providers here, you know, oftentimes are talking to doctors at insurance companies saying like, this patient really needs 3 more days of IOP, you know. But here we you know, $10.7 billion. That's a lot of money, right? Semaglutide is the most prescribed, and in the fourth quarter of 2022, again, this is like very old data, right? 2 years ago, 9 million prescriptions for these medications were written, and 7 million of those 9 million were semaglutide. So what are the benefits? You know, again, I think is really important. One, so that we can connect with our patients and give them truly informed consent, and most of them have access to these studies anyways. But 2, so that when I'm talking to an endocrinologist, I can go into those conversations, again, without an agenda, you know, and we can have a collegial conversation where I get to share what I bring to the table, and hopefully they learn something from what I bring to the table, and they get to share their perspective, what they bring to the table, and hopefully I learn a little bit from that too, you know, or a lot. But those conversations and those connections do not happen if I'm like on a soapbox, you know, and coming in, you know, to the conversation with like, I can't believe you talked to my patient with X, Y, or Z eating disorder about this class of medications, you know. That immediately is a off-putting kind of presence to bring into a room. And these are very complex. This is a very complex topic, and people have very, very, very strong feelings about that. And I appreciate that too. So any of you, as we go on in this conversation, are having strong feelings, like, take care of yourself, please. That may happen, and we all want to take care of ourselves first and foremost, and also hopefully we're all I know I'm going to be changed after this, right? So the benefits. We know that there is a robust and huge randomized, double-blind, gold standard body of literature that shows these medications are efficacious for type 2 diabetes and weight management. And there are some important weight-inclusive or weight-neutral benefits. Hemoglobin A1C drops. Decreased risk of myocardial infarction or stroke in people with cardiovascular disease. Person X might say, that's really important to me because, 5 of my relatives died of a heart attack by the time they were 60. Person Y might say, nobody in my family has ever had cardiovascular disease. I don't have cardiovascular disease. If I develop high cholesterol or diabetes, I'll just call my concierge doctor and go to the pharmacy and pick up my medication and pay the copay. No big deal. And that's great too, right? We get into problems when this camp is saying like, that's terrible. And this camp is like, I couldn't even get that medication even though I have terrible type 2 diabetes and, everybody in my family loses limbs and then eventually dies of coronary artery disease and type 2 diabetes. And then we talk about weight loss, right? As an eating disorder professional, my training and my bias is oriented around like, why are we even talking about weight? Why is this the focus? Because so much of my work is decentering that topic for my patients, and also combating, hours and hours in blood, sweat, and tears, combating weight stigma, combating fat phobia, and trying to help patients who are disproportionately affected by the culture that we live in, that lives in medicine too, right? So is weight loss a risk or a benefit? For who? Who gets to say? It's a really important question. The primary care doctor, the eating disorder specialist, social media. Is it TikTok these days? TV, professional organizations, whether they're the endocrinologist association or eating disorder associations, eating disorder advocacy organizations, activists, advocates. Is there a place in our current scope of practice, in our current, the way that we deliver care to patients for patient voice and choice? Is there a case and a space for nuanced care? I think in the eating disorder world, we can be very paternalistic in the way that we deliver care, right? Particularly at higher levels of care, like we have residential here, PHP and IOP, right? If, we have to have boundaries, guidelines and rules to keep everybody safe, right? When those become rigid and we lose the capacity to individualize care and tailor care truly for the individual, we're doing a disservice at least to some of our patients, right? So what are the risks of these medications? Again, in the eating disorder field, I think we are well aware of the risks, right? We live and breathe and talk about the risks. So GI side effects, nausea, vomiting, diarrhea. It's pretty much the rule, at least when people are starting or escalating doses. And that usually lasts for several days after their injection if they're on injectable. Less common, but very serious, would include gastroparesis, hypoglycemia, hair loss, ileus, which is essentially when your colon stops working, and could put you at risk of having a rupture and becoming septic and dying, pancreatitis, certain forms of thyroid cancer, renal failure, dehydration, malnourishment. And despite all of this, most people, when asked, like, do you want to go on this medication, will be like, yes, sign me up, right? As a psychiatrist, I'm like, you gotta be joking me. Like, I'm like, you're severely depressed, you know, you've been suicidal for like 5 months, can't get out of bed. Would you be open to considering Cymbalta? You know, I don't know about that. You know, what are the side effects? You might get a little bit of stomach upset for the first couple days, or we'll start low and you'll have none. I don't think so, but thanks. You know, so very different sorts of conversations with these medications. We have a paucity of long-term data on the newer medications, you know, the most potent ones that we're hearing about right now. The longest study lasts 2 years, right? That is not a long time for a medication that you need to be on for life. Certainly not a long time when it's a medication that made it into treatment guidelines for adolescents, right? There are the problems of cost, overdose, scarcity of supply, compounded versions and illicit sources, which sometimes contain substances that either aren't what they're supposed to be or are in a differing dose. You know, cost on average is around $1,100 to $1,200 a month for the newer medications. And some insurance covers it, some doesn't. Specific concerns for patients with eating disorders: weight loss, impact on current eating disorder. How about if they have a latent eating disorder and it comes to full bloom with these medications? How about if they have a past eating disorder? How's it going to affect eating disorder treatment engagement? You know, the answer to all of this largely is we don't know yet. You know, there's lack of routine screening for eating disorder in the vast majority of primary care and endocrinology practices. We have some endocrinology practices local to us in Northbrook who actually have weight-inclusive psychologists in their practices, and everybody gets screened. That is very rare, but it is a really, really, really good practice. So oftentimes patients are either not diagnosed with an eating disorder or they're misdiagnosed. And probably the most risky misdiagnosis, again because of bias, is people living in larger bodies who are being misdiagnosed as having binge eating disorder, but who really have atypical anorexia. That is a recipe for disaster, even with like super close monitoring. I gotta believe there may be other options that this person may pursue. But most of these people get prescribed the medication, and I'll see you back in 3 months or 6 months, right? And if they're not seeing like me every week, you know, there wouldn't be somebody saying like, God, how long's your depression been back? About 2 months. Any new medications that you started? Oh yeah, I'm on Wegovy now. When did you start it? About 2 months ago. Just think maybe of sharing that with me. But this is part of what we'll talk about in the best practices, right? Always ask. Literally, like every time I see patients now, I'm like, have you started any new medications in the last week? And many of my patients I see every week. You know, some of them I know because they're in my our residential treatment center. But a lot of them I don't know because they're outpatient or going home. So limited evidence base, impact on weight stigma and fat phobia. Again, all we hear is weight loss, weight loss, weight loss, and it's pretty persistent. That narrative has wrecked lives of people that we treat. And then worsening healthcare inequities for historically minoritized patients. This is a huge concern, particularly because if we go to just medication, we risk neglecting systemic problems. So that includes racial inequities in the eating disorder field. I can't see the people on Zoom, but I can see the people in this room, and it's pretty white. That's the rule rather than the exception at the vast majority of eating disorder events and conferences that I go to. So we know that, I'll talk in more detail about some of the racial inequities, but we know that people have different access to food variety. We know that people have different access to healthcare. We know that people have different access to safe green spaces. And it's really minoritized and marginalized populations that are most susceptible to the storm being created by big food, big pharma, big tech, add diet and weight loss industry to that too. So what about type 2 diabetes, where these meds started? It's one of the top 10 causes of death worldwide, and it's most common in higher middle class, upper middle income countries. In the US, cardiovascular disease is the leading cause of mortality and morbidity with patients who have type 2 diabetes. And Black patients and Hispanic patients have a disproportionate burden not only of type 2 diabetes, but of health consequences of that, including cardiovascular disease. We know that the diabetes-related risk for coronary artery disease has actually declined for white people in this country since 1990, and it has doubled among Black people. And particularly in patients with type 2 diabetes, cardiovascular mortality rates are the highest for Black people. So it's critical that we understand and dismantle the barriers to GLP receptor agonist use among marginalized groups for very appropriate medical indications. And about that Oprah special. A billion people have asked me if I've seen it. I haven't seen it. I've read a lot about it. So I share this with you as a person who hasn't seen it, and as a person, again, who is an advocate for the needs of people with eating disorders. This is from Oprah. I decided to leave the WW board because this special was really important to me, and I wanted to be able to talk about whatever I want to talk about. Freedom. Winfrey donated her shares to the tune of $2.5 million to the National Museum of African American History and Culture. So nobody can say, oh, she's doing that special, she's being paid. No, you cannot say that. Unless you're an eating disorder advocacy organization. And I share this as a call-in to all of us in the eating disorder field, because we must do better. We must do better, and we can do better. I know so many people, really good people who've done amazing work and continue to do amazing work, raising awareness and fighting the battle every day for people with eating disorders. But one of our organizations, posted a response to Oprah's special. And when we step back and think about the process, I think we messed up. We're extremely concerned about the lack of consideration for eating disorder in Oprah's special. I agree. Eating disorders are not part of this conversation, really. Fat bias isn't. Weight stigma isn't. While Oprah's personal journey and body autonomy is very important, yes, the special, unfortunately, perpetuates diet culture, anti-fat bias, and so goes the statement, right? In my world, we call that a racialized aggression. Oprah gets to say what Oprah does with Oprah's body, period, end of story. As a thin white person, it's never my business to tell Oprah, or to cast any judgment on the special that she put on because she wanted to. One of the most famous Black women who's lived in a larger body her whole life, right? And at the same time, what Cito's talking about is really important, right? But when we think as a field about who we're including, who we're not, we have a lot of work to do, right? If I'm a Black person on a larger body and I'm like in one of the eating disorder circles and I happen to be on a GLP, and my cardiovascular indicators are improved and my diabetes control is improved, I get a message from this like, don't talk about that or you won't be included here, right? We want to do better. And this is why it's important, because when we look at racial inequities in GLP groups, in GLP medications, like in many, many things, like this is the same for Suboxone. This is the same for many different kinds of medications. If you look at the upper right slide, or upper right graph, you'll see at the very, very top would be uptake of these medications for white people. And this also is done on a study of about 1 million people who are privately insured. So even when controlling for socioeconomic status, this is true, right? And below the white persons, you have Black and Hispanic folks with much lower uptake of these medications. Consumption, yep. So whether or not they've been prescribed these medications. And that holds true if they have cardiovascular disease, and again, which is the highest mortality in diabetes, and type 2 diabetes. All of the patients in that study had type 2 diabetes. So the rates of type 2 diabetes in eating disorder populations are the highest in patients with binge eating disorder. Up to 20% of people with type 2 diabetes will have binge eating disorder, and around 30% of people with binge eating disorder will have type 2 diabetes. And we cannot know simply by looking at somebody, and we cannot assume simply by looking at somebody whether or not they have binge eating disorder and whether or not they have type 2 diabetes. We know both are more common in persons living in larger bodies. And unfortunately, both those with type 2 diabetes and people with eating disorders living in larger bodies are recommended and referred for weight loss interventions. As I mentioned before, there's a near universal either poor screening or lack of screening altogether. And there remains a knowledge gap between primary care doctors, weight management practices, leaving us oftentimes having to share the other side of the story. And that's usually where we stop that conversation. But we also need to do better and call those clinicians and have collegial conversations with them, because people don't learn if we don't have a seat at the table. And if we don't have a seat at the table and even if we do have a seat at the table, if we're throwing stones, people are not going to want to learn from us. And our patients deserve it. At the end of the day, our patients deserve this, because if you have type 2 diabetes and you have binge eating disorder, you're getting almost 180-degree opposite message from your primary care doctor than you are for us. And that's a really fragmenting and confusing experience, I think, for a lot of our patients. So we know from a lot of data that one of the biggest risk factors for the development of an eating disorder is thin bias, right? And toxic idealization of thinness. Weight bias worsens people's health, worsens people's eating disorders. There are studies that show that. In a huge, weight bias in our country is toxic and has devastated lots of people's lives. That is a real thing. We need to do better on that front too. Okay, so what's the data? So I want to start with just some data, just some of the biological data from the semaglutide studies. Not because I'm being paid by Novo or Eli, I'm not, nor any other pharma company. Learned that in my residency, and those are words to live by. So this is the STEP 5 study, which is the one that sort of like was critical to get it approved for type 2 diabetes. Overwhelmingly female, overwhelmingly white, 300 patients, 104 weeks. It's the longest one that we have. Primary endpoint, of course, was % change in weight. And other endpoints, which are the ones that I'm interested in as a weight neutral, weight inclusive practitioner, change in blood pressure, hemoglobin A1C, and waist circumference. So this is the waist circumference, blood pressure, and hemoglobin A1C data. And what you see along the bottom is, so this is like % decrease. So you see improved, like lower blood pressure. I generally don't even like look at the upper left one, right? So lower blood pressure, and at the very bottom on the right is hemoglobin A1C. Much lower hemoglobin A1C. The gray part are people on placebo, and the dark circles, the darker line that looks navy, are people on semaglutide. Yep. And this also is a slide that I think is important. The first time I saw this slide, I was like, why are you even showing this? This is the slide about weight and weight loss. Because honestly, I didn't know at that time. All I knew was people were losing way too much weight in my mind as an eating disorder clinician. So what they show here, and this data has changed a little bit. So on the large graph, you see % body weight change. And by the end of the 104 weeks, it's about, right around 15%, right? The important one for me, and it was very eye-opening for me, is the one on the right, which shows what % of patients had greater than 5% loss of body weight, right? So if you're just to put it in context, if you're a 100-pound person, that's 5 pounds. If you're a 300-pound person, that's 15 pounds, right? 30% of people did not lose more than 5% of their body weight. I was like, oh, I thought everybody did, And in my clinical experience of having people on some of these medications, not everybody loses weight. They oftentimes, unfortunately, feel really bad about that. And I'm like, oh, again, eating disorder bias, like, oh, thank God, you're still eating, you still have appetite, your hemoglobin A1C is better, your blood pressure is better, it's like win-win. So this is the slide that I talked about. So the older medications in this class are on the far right. And look what happens as you go towards the left of this slide. This is percentage body weight lost. And you start off with, liraglutide or dulaglutide, 2-3%, not huge. But as these get more and more developed, you're shooting up to 15% body weight loss. That's a huge difference. And as a prescriber, not that these are medications that I am not an endocrinologist, I'm not a primary care doctor. So when I'm talking to patients about these medications, I'm talking as their psychiatrist and eating disorder / addiction / trauma psychiatrist. But this is a trend that concerns me, because it's also the same trend that we saw with OxyContin is the solution to pain problems, right? And now 20 years later, we have fentanyl, and we have 100,000 people in our country dying every year. So what are the studies with binge eating disorder? There aren't many. There are not many studies on patients with eating disorders. So this was an early one, randomized, controlled. It examined the impact of liraglutide at a low dose, 1.8 milligrams, versus diet and exercise on binge eating scale. It was 44 non-diabetic people living in larger bodies. And the participants who received the active drug showed significant reductions in binge eating scores from 20, which is moderate, down to 11, which is non-binging. And also significant decreases in blood pressure, fasting blood glucose, and cholesterol. Limitations, it was a small N, and it was a short duration of study. And these folks also had lower severity binge eating. No industry disclosures. In 2023, Jesse Richards published an open label trial looking at semaglutide with binge eating scale scores in patients with moderate to severe binge eating disorder. Profound effects, again, on the central brain-related circuits. And 3 groups were studied. So these are the results. So semaglutide only on the far left, semaglutide plus either topiramate, Topamax, or Vyvanse. And then on the far right are people only on older medications like Vyvanse and topiramate. And on the y-axis, you see mean change in binge eating score. So significant drops for the patients who were in the 2 semaglutide groups. I will note that Dr. Richards, the first author, is on the speaker bureau of Novo. That's relevant to me. I encourage everybody to read the disclosures when you're reading a paper. I read a lot of papers. It's fun for me. I just have a hungry brain, and I feed it a lot. This is a prospective controlled study in 2020, and it was open label. And the patients in this study were, there were 60 patients. All of them had elevated hemoglobin A1C. And they were either on metformin therapy alone, or they were on metformin therapy alone and had a diagnosis of binge eating disorder. They were randomized to dulaglutide, Trulicity, which is one of the sort of middle-aged one of these medications, at a 1.5 milligram dose, or a sulfonylurea, which is a kind of old school diabetes medication. Most patients were female and white. It's a trend. Authors disclosed no conflicts of interest. And what they found at 12 weeks, again, only 3 weeks long, they were looking at binge eating scores on the BES. Those were significantly lower, and also hemoglobin A1C significantly lower. But what happens after a year? What happens after 5 years? I have patients who haven't had access, for whatever reason, to the GLP med that they were on. And it's not pretty. Like it disrupts their lives and it disrupts their recoveries. There was a double-blind controlled trial that came out of Penn, Kelly Allison, and these are for folks in these are for folks living in their bodies. It was a 17-week double-blind study, controlled, of liraglutide. Again, like one of the middle-aged ones, but at a higher dose than the previous study, at a dose of 3 milligrams. This was actually a racially diverse sample, which is nice, but only 27 participants and only 17 weeks. And they found no significant decrease in objective binge episodes by week 17 between placebo and liraglutide. The remission rates of binge eating disorder were roughly the same. There was a trend towards a little bit more in the active group. There was no change in the depression scale, no change in, as measured by the eating inventory, cognitive restraint, disinhibition, or hunger. There was significantly larger weight loss in the active group, to the tune of, roughly 10 pounds. So, given all that, how do we, our patients are on these medications, and it's, part of what we need to do is educate ourselves so we can have truly informed decisions, and ideally nuanced, agendaless discussions with our patients, so they have some sense of what some of the risks are, what some of the benefits are, and how to make these decisions for themselves. So the big question for me is, are these medications compatible with weight-inclusive care? It's probably the biggest one. Attunement to hunger and fullness. Eating regularly throughout the day. 3 meals, 2 to 3 snacks. Combating weight stigma. Are they compatible with fat positivity? How about body image? And what impact do they have on eating disorder cognitions? And I've seen different effects for different patients. That's important. Quality of life is also an important piece of this. So assume nothing and listen to the patient. I think, again, I come in with my, big doctor brain, and I've been treating eating disorders for 20 years. Here's the deal. But when I come in with a beginner's mind, and I can be present in the room with another human being, and I can listen to them, I learn a lot from them. And I learn a lot about my own bias. That doesn't happen if I go in and I'm like, I'm the doctor, I'm an eating disorder specialist, and here's the deal, Practice humility. How often are we saying to people, yeah, it's complicated. We don't know yet, Or we don't know for you. Knowing what I know for you over the last, X amount of years or X amount of months, here would be some of my concerns. Do you have any of these? What are your hopes? What are your motives? All of that, And we need to also, this is something that drives me crazy in medicine. It's so fragmented, right? So my patient may go to a GI specialist and be put on, or be told, you know what, I think you have you have overgrowth in your small bowel. Don't eat any sugar. In fact, don't eat any carbs. Your BMI is 18, so you're doing great. But when we know what a patient has, all of the things, including their medical diagnosis, their eating disorder diagnosis, when I'm talking to them about a treatment, I take into account more than just the treatment, that treatment's effect on the eating disorder. I also must take into account, well, what's my treatment? Because I'm laser focused on this eating disorder. What impact is that going to have on their coronary artery disease? What impact is that going to have on their type 2 diabetes? What impact is that going to have on their depression? You get what I'm saying, right? So what do we do when there's a limited direct evidence base? In the words of a wise mentor of mine, Tim Brewerton, we rely on the three-legged stool, right? So established evidence base for relevant similar conditions. Are there any evidence-based treatments that work for things that are similar to this, or things that might be similar to this? We rely on our own clinical experience and expertise, which again is inherently limited and biased. I have not treated every patient with an eating disorder, or every patient with addiction, or every patient with a million other psychiatric diagnoses. And last, but far too often, either not listened to or discounted or pathologized. We do a lot of that's your eating disorder talking, right? Patient values and patient preferences, and that must be individualized. So harm reduction is a very good evidence-based, from a public health perspective, way to go about doing treatment, and I think it's applicable here. Its principles have application to eating disorders, including enduring eating disorders, as well as many other chronic health conditions. And the treatment philosophy was really initially developed as an alternative to abstinence-based approaches to addiction. I think even abstinence-based approaches to addiction are essentially and fundamentally harm reduction, because nobody enters treatment on day one and says, I think I want to stop drinking and smoking and gambling and, purging and overeating or starving myself. Nobody enters my types of patients. They are out there. You see that there? They are out there. They're just not the patients that I take care of. And I own that. I see a very small subset of patients more broadly. So this treatment really prioritizes, first and foremost, and centers individualized patient-centered goals. And the focus is really on improving quality of life and reducing risk as defined by the patient, not as defined by me. So we always, if you leave here with one thing in your head, I hope it's who gets to say. Harm reduction respects the rights of people who seek treatment. If a person is reaching out for help, that is, in and of itself, is a huge thing to celebrate. That is a victory, and I never take that lightly. As a person who knows how excruciating it is to ask for help, even somebody showing up at the office or on the Zoom screen is a victory. It's a commitment to evidence, a commitment to social justice and collaborating with people who seek our care, the avoidance of adding judgment, adding bias, adding stigma, adding discrimination in any way, shape, or form. That is not what any of our patients need. It's non-coercive in practice from a clinical stance, and really meets patients where they are. And it's trauma-informed. Ideally, it's trauma-informed. Trauma-informed care really rests on safety, collaboration. I drop my agenda, or I'm at least honest about it, transparent. Focused on empowerment and resilience, and voice and choice. The goal is always to increase the person's experience of choice, the person's experience of freedom. Not how freedom looks from my eyes, but what freedom means to them. And it looks different for different people, particularly people with eating disorders, because food is so complex and people's histories with food are so complex. It recognizes that every person's experience is unique and requires an individualized approach. It rests on building peer support and connecting people with community and connection and inclusiveness. It's culturally attuned, gender inclusive in its care system. It addresses systemic racism, offers gender responsive care, and recognizes the healing value of traditional cultural connections. And it's essentially humble too. You know, the more, now that I'm old, the more I know, the more I realize I don't know at all. Like, I used to hear people say that, and I'd be like, all right, I know a lot, you know? But I've been a lifelong learner, and I continue to be, and I'm grateful for that. So lots of unknowns for people with eating disorders, no doubt about it. No well-controlled evidence base, but again, we can rely on that stool. Always, always, always including patient preference and patient choice. We don't know yet if the GLPs, when they're used for an appropriate medical indication, decrease core eating disorder symptoms, increase eating disorder symptoms, have no effect. We don't know how long those last. We know for sure that when people stop taking these medications, they stop working, right? And everything that they started taking the medication for comes back. So these are, kind of like Suboxone for a lot of patients, lifelong medications. If there are benefits for some patients with eating disorders, how can we identify who will be helped and who will be harmed in a personalized, flexible, non-dogmatic way? And there's a tremendous amount of dogma in the eating disorder world. There's just a lot of it, and we hold on to it. I think because it's what we know and it helps us feel safe. In the interest of time, I'm gonna skip to the next slide. Here's what dogma does to us. It leaves us looking like the box of crayons on the left. And I think all of us, like, if you have another crayon for me, I'm available. Like, bring it on. I love this quote from Ralph Waldo Emerson: "A foolish consistency is the hobgoblin of little minds." I just love that. So let's add some crayons, okay? Let's consider dietary restraint. I hear the word and I have like a feeling in my stomach, like it elicits a visceral response as an eating disorder person, and also as a person who's, who has lived recovery experience. But does it always indicate the presence of a restrictive eating disorder? And this is from a paper published in the International Journal of Eating Disorders in 2023. So is it possible that there's pathological dietary restraint, the stuff that we see day in, day out as eating disorder professionals, skipping full meals, compulsory food rules, not eating whole groups of food? Are there forms of non-pathological dietary restraint? Maybe? How about gluten for folks with celiac disease? Okay, that's a non-pathological form of dietary restraint. People with celiac disease, practice dietary restraint and don't, eat gluten. Unless they have eating disorders and they're using it as a form of purging. Like that happens too, right? How about peanuts for those with anaphylaxis or a severe allergic reaction? Or meat for people who are vegetarian. They don't eat meat, and it's a personal choice unless they have an eating disorder, right? What about type 2 diabetes? We do, the medical field as a whole, including us as eating disorder professionals, does a very poor job in treating patients with type 2 diabetes and a comorbid eating disorder. And I think a lot of that is the fragmented pieces of advice that must just cause a swirl for our patients. How about stopping eating when full? Is that a form of non-pathological dietary restraint? Well, I guess so, if you consider like stopping eating when you feel full and you feel satisfied is you stop eating and then you're in a place of like restraint of eating more. So I share this to sort of, walk you through my process when I first started considering, well, dietary restraint, like that's a bad word, like why is this published in iGED? But it's bigger than, it's a much bigger and much more complicated, like, is it dietary restraint for who? And in what context? And in what circumstances? So what's a practical way we can talk to patients about this? So this is a 6-step practical guide that you can use, regardless of your licensure, regardless of your scope of practice. So step 1, ask and ask regularly about medication changes. People don't think, even patients that, I've treated for like 5 years every week in a medication management process group, why didn't you share that with me? You know what, I didn't think about it. And we talk all the time about, that's like a blind spot that for me as a clinician, we talk, and I say this out loud to my patients, that seems like it might be like an eating disorder blind spot, like a subconscious, like I don't want to share this with Dr. Kim because I don't know how she feels about it, and I definitely don't want to hear from her like, you shouldn't take this medication, or you shouldn't do this. So step 2, if a patient is on a GLP, these are patients with eating disorders, do they have an FDA-approved indication for use of the medication? And on the earlier slide, I showed you exactly what those indications are. Then, what are their goals? And this is where we use discernment. This is where we use clinical practice. So let's say they do have an actual indication. If they don't have an indication and they're misusing the medication, I think that we all know like how to handle that, right? So let's say they have type 2 diabetes, or now they have cardiovascular disease without type 2 diabetes. We focus on informed consent in line with the scope of our practice, right? For me, as a medical doctor, a psychiatrist, medical side effects, we talk about absorption of medications, lack of studies, impact on metabolism, impact on eating disorder, what monitoring would need to look like, weight stigma, lifelong treatment, alternatives. That also needs to include, yes, it has been shown to improve type 2 diabetes outcomes, depending on when the longest study is from. For 2 years, it has shown this, and in order for those effects to happen, you're going to need to take the medication for the rest of your life, presumably at this point. That may change at some point when the next thing, there's another thing that came out, I don't know if any of you guys have read about it, it's called the endo barrier. It's a device that's inserted into the small intestine through a tube that lines the small intestine, and essentially we could talk about that in the question. If anybody's interested, you could talk to me afterwards. But I share that to say one of the things that endo barrier is being pitched for is well, hey, maybe instead of taking GLPs for life, they can have the endo barrier, and then the endo barrier is removed in a year, and the effects continue, at least for the next 2 years. So this is evolving. It'll be a different informed consent as the information keeps evolving. And a very important step is asking for an ROI and call the PCP or endocrinologist. If you're a therapist, if you're a dietitian, if you're an addictions counselor, if you're a psychiatrist. Doesn't matter what your licensure level is. If you're the patient's eating disorder therapist or treating them for an eating disorder in any way, shape, or form, you must call the PCP and the endocrinologist, because a lot of times they have no idea the person has an eating disorder. Or, just as frequently, they know a person has an eating disorder and they have no idea what that means really in real life, right? And if we don't call them because we hate what they're doing, or we see them as like, first of all, we don't know who they are. I've been surprised a lot of times when I pick up the phone and the person on the other end is like, well, here's, they're all there. Nobody comes into this line of work because they want to hurt people, right? None of us came to this, lecture today because we've dedicated our lives to hurting people. No, they haven't either, right? There are things that I know that they don't know. There are plenty that they know that I don't know, And when we connect, I get to learn in that process, and they get to learn the most important. Nobody's getting eating disorder information if we don't call them and conduct ourselves in collegial and civil and humane ways. That hurts our patients. That is actionable. So get those ROIs. And then collaborate and communicate with the patient's support network to increase support. Because there is risk. There is risk. Even if you didn't have an eating disorder, there'd be risk. And then initiate closer monitoring, more frequent follow-up. Because again, most of these patients are getting the medication and then, I'll ask my doctor when I see them again in 6 months, Our patients need, especially when starting a medication like this, very, very frequent monitoring. Misuse is a concern. We know that poison control hotlines, calls for GLP meds have increased 300%. I think the clinical approach, if a person with a restrictive eating disorder is on a GLP med, should be really driven by the level of medical and psychiatric risk, up to, the higher the risk, the more urgent or possibly emergent the intervention needs to be. So in summary, these medications have multi-system impact. They have specific FDA approvals. Their impact on patients with eating disorder to date is largely unknown. We have very limited data. Much more data when it comes to their impact on hemoglobin A1C, cardiovascular disease. There's a lot of interest in energy around these could be a global sort of addiction treatment, again, because of what they do to the reward center. Most of that data is animal studies. There's a limited amount of it in human studies. There's tons of anecdotal reports. Shut off my food noise. I stopped skin picking. I don't gamble anymore. I don't even want to. So there's a lot of energy and a tremendous amount of investigation around it, but again, very little is known, but new stuff coming out all the time. Eating disorder clinicians are well suited to ensure informed consent, covering specifically potential eating disorder risks, to intervene on weight stigma and fat phobia, to support weight neutral care, and to increase other disciplines' capacity to understand what that is and maybe put some of those practices into place, to ensure an accurate eating disorder diagnosis, to communicate with the prescriber, and to increase monitoring. All of those are things that are actionable on our end. My practice is to use harm reduction and trauma-informed approaches. And with such scant data, again, we rely on the 3 pillars of what we have, and that's parallel evidence approaches. So harm reduction is an evidence-based treatment for many different types of chronic illnesses. We rely on clinical experience and expertise, and last but certainly not least, patient preference. And always, always keep in mind who gets to say. You know, I get to say for me, and that's where what I get to say ends, in my opinion. And now we can spend some time doing questions.
Dr. Kim, I have a question here I'd like to read.
Okay, and I'll repeat the questions so that the remote viewers can also hear them.
Curious if you've had personal experience with a patient with atypical anorexia who may have used a GLP-1 and what you saw in cognitive and behavioral patterns. I know research is still pending, but wondering about a single case example you've seen.
So I'm very grateful that none of my patients with atypical AN have gotten on these medications. A lot of them have thought about it, but none of them have. I've read case reports of, you know, again, I think this is the biggest risk. One of the two biggest patient groups that are at risk for being put on these medications. Those patients in larger bodies with atypical anorexia, and two, people in larger bodies with non-purging bulimia, who are also engaging in restrictive eating and being put on these medications. I've had a lot of patients with atypical AN and OSFED try to get these medications, sometimes, you know, online from illicit sources, but they've shared that with me, and with their support, you know, sources of support with their primary care doctors, we've been able to come to some alternatives, and there are alternatives. Again, it's constantly weighing the risks and benefits. And that's going to be a different equation for any patient. Okay. Can I take one from the room? Anyone in the room? Rachel? And then Robin.
You've talked about like the different types of agents, like the older ones and the newer ones. What's the like difference between them other than like dosage, like potency, or you can put up that slide of like the.
Yeah. Can I have my slides back, Sal? So the the pharmacologic function of each of the medications in the class is to bind to the GLP receptor, which is all areas of our body, and to stimulate it, to activate it. So every drug in that class, let me get back to that slide. Oh, here. So all of the medications on the bottom here have that as their mechanism of action. You know, so largely what's different is who developed them, who marketed them, some of them what their indication is for, whether it's, you know, any of them that are indicated for type 2 diabetes and weight management have started with the type 2 diabetes indication, and then later, usually again at a higher dose, increasing potency, get the indication for weight management. You know, and I've had patients with histories of binge eating disorder, and alcoholism and trauma, tons and tons of trauma, which trauma of its many, many different types of forms impact at very early developmental ages the functioning of that reward center. So patients with that constellation of symptoms who've been, you know, recovered from, let's say, binge eating disorder, you know, for a year, you know, and has type 2 diabetes, right, with good hemoglobin A1C on medication that is not a GLP, convert to semaglutide in the Ozempic doses, and do okay at a low dose on the Ozempic dose, right? And run into huge problems after they start Mounjaro, right? Or after they start Wegovy. I've seen it several times with the transition from Ozempic. Again, normalized eating, eating like 3 robust meals a day, all different food groups, eating snacks when they're hungry, not eating snacks when they're not, having some stability, in their blood pressure, in their diabetes control, and then, well, my doctor said that Mounjaro was better, and they have no appetite at all, like eating dinner, but only eating dinner once a day because their spouse reminded them to eat dinner, right? And then running out of it and being like, I can't stop thinking about food. Yep. But also when that, I've had several patients that's happened to and have said like, I do not want to go back on that medication because I don't want to live this way. Right, so then I talk with the primary care doctor about, well, what are some alternatives to either like that medication or that dose? Like how about going back to like the smallest dose of Ozempic or even liraglutide. If that medication was very helpful for the diabetes, and they've had like these are patients who've had like, I might lose my eyesight because it's been so poorly controlled and I haven't really even had any energy or desire to take care of myself on the medical side. So these aren't patients who, maybe have a hemoglobin A1C of like 5.9. They're usually in like the 10s, 12s before they get treated. Does that make sense? Did that answer your question? Yeah. Okay.
Okay, so we had a couple other questions come in. Can the use of GLP-1 medications increase the risk of people developing eating disorders? Have you had any patients that developed an eating disorder because of taking GLP-1 medication?
So I treat people who don't have eating disorders too, people with addiction, people with just mental health issues, and I have not seen people develop eating disorders. My N is small, but theoretically, one of the things, I'm thinking about it how I think about what has happened to cannabis over the last 20 years, right? The potency of cannabis that adolescents' brains are exposed to today is infinitely more potent than like what people in high school, when I was in high school, were walking around smoking, right? And because of that increase in potency, kids who otherwise would never ever experience psychosis, who have like, a 5% genetic loading, I'm just like throwing out numbers, right? 5% genetic loading, they go through life never being exposed to high potent THC, never have psychosis. 5% genetic loading, being exposed to high potency THC, as the frequency of that increases, they're more and more susceptible to developing psychosis. So I think a similar thing is what we're probably going to see with eating disorders. We know that these are metabogenetic illnesses, and people have a certain amount of genetic loading that they just come into life with, and again, we know that weight loss, especially rapid weight loss, theoretically an eating disorder may emerge from a latent state to a full-blown eating disorder state. Okay. Robin, and then Lauren, and then Melissa.
So there's been data out for quite some time about differences in the brains of certain forms in terms of satisfaction response, satiety response, pleasure response. Is there anything known about what these GLP-1 receptors do?
No.
On that?
Nobody is. Nobody is going, oh, sorry. So the question is, there's a lot of data on what the brain changes are with enduring anorexia, right? I would say the sidebar to that is, yes, there is a lot of data, and probably 99.9% of it is on white patients, right, in a certain socioeconomic class, right? So for those patients, to my knowledge, nobody is interested in using GLPs for them. I don't know of case reports either. But what your question makes me think of is Guido Frank. I ran into Guido Frank, who's out in California at, I think he's at UCSD, who has a grant and is studying weight-restored anorexia, basically a ketogenic meal plan, calorically equal to a non-ketogenic meal plan for weight-restored people with anorexia who continue to be plagued by body image concerns, obsessions, because there are case reports and cohort reports of patients with anorexia actually, being able to not only maintain their weight recovery, but also have decreased obsessionality and improved body image. Yeah. Lauren.
I guess my question, it's more if you can maybe just speak more on the use of this with adolescents, because what comes to mind from this whole presentation, it's just seemed like there's a lot of things at play, a lot of things to look at and talk about.
Totally.
So if you're thinking about a teenager, in that, like, have they even developed enough to get all that data? I guess my
no is the answer to that.
Is this something that's like a first line medication that is also being used with adolescents? Or I don't know if you just said anything.
No, I hope not. Oh God, repeat the question. I always forget that. So is this, Lauren has asked, like, is this like a medication that's actually being used as sort of a first line approach to adolescents? Right, is that the question?
Yeah. Being
Yep.
used to treat what?
Right, being used to treat what? Like, what are you thinking?
I guess I'm thinking, personally, I just think this is being looked at if, I just keep gaining weight, so this will help control like my eating and,
Yeah.
So I guess like adolescent obesity, if you will, if this is being used for that.
So the question is, is this being used for adolescents living in larger bodies as like a means of weight control, right?
Yeah.
So none of the pediatricians I know are prescribing it. I happen to be on a cross-organizational work group with the AAP. I spoke out on the media a lot about the guidelines and how alarmed I was by them and appalled I was, the first 20 times I read the summary. I've never read the full guidelines, which are like hundreds of pages long. But in response to all the backlash they received, they created this cross-organizational work group on eating disorders that includes people like me, people in lots of different disciplines, eating disorder primary care doctors, and one of the things that I learned, it was really hard to show up to those for the first probably 6 months. But one of the things that I learned from that, again, is like, okay, these are not people that are at all interested in like hurting kids, So some of them will share like these are considered, for kids who have like already diabetes, who are at extremely high BMIs. We're not talking about kids whose BMIs are 28 or 30 or 40 even. and I don't know. You know, like I honestly, not a pediatrician. I can tell you none of the kids that I've like come in contact with locally here have been prescribed them. I would have like huge reservations about putting my kid on it, and I haven't walked in the bodies of these parents, these families, these kids, but I wouldn't do it, you know.
I guess my follow-up is just this fear of like the fat phobia.
Totally.
Of this thing of.
To a kid.
Exactly, of this kind of like, well, you're gaining
whose
weight. Well, here's this
identity
medication
is
you can
developing.
take,
Yeah,
so
no,
you don't.
1000%.
I've had a 17-year-old on Ozempic before, no diabetes, no, the pediatrician and parents agreed to, they're just staying in their body.
Yeah, I mean, that's a huge, huge, huge concern.
And
Like,
carefully
my
manage
concern is like 20 years from now, 10 years from now, we're gonna have like a huge epidemic, an even increased number of people with eating disorders. You know, so that's a huge, because any medication is gonna operate differently. To begin with, these are like, those have all those risks for adults in larger bodies. But when we're talking about a developing brain and a developing identity and all of the socio-developmental tasks for these kids in our current environment of like big tech, you can't get away from the bullying, even if you want to come home from school, but it's still there, right? It just seems like a recipe for disaster. One more question, and then we'll.
Is there any conversations, research, indications for food addiction and these medications?
What? She said the word. So there was a question from the audience about, is there any research or conversation about or talk about use or efficacy of these medications for food addiction? So food addiction is a very controversial clinical entity. I think it's often conflated with diet culture, or it means like it's converted to like, well, that must mean like abstinence and weight loss, but the literature does not necessarily conflate that. And so there's a lot of literature about food addiction, what it is, what its prevalence is, the disparities among race in food addiction diagnosis. It's largely excluded and with a lot of emotion excluded from the eating disorder community. But there was a study that came out just in the past couple of months, and I don't remember the details of it, but there is a study that I'm aware of that looked at food addiction scores in a cohort of patients who were on GLP meds.
Because you had made a comment where there was subjective information about it helped reduce my skin picking or some of these others. So it's interesting how that might.
Yeah, no, so the comment was, you know, that I made a comment earlier in my talk about how there are lots and lots of anecdotal reports, and there are qualitative studies that have looked at social media and quantified, you know, the sort of like off-the-cuff personal remarks, and there's a large number of people who say I'm not. There are studies actually that look at alcohol consumption in people who are on these meds for diabetes or on these meds for weight control, and it's decreased in folks who are on it for weight control or weight management, but it's not decreased, and not significantly decreased in those patients with type 2 diabetes. But there's a ton, this is why there's a lot of interest in, you know, whether or not this could be used for other uses. I find it interesting that we don't have any data. You know, there's a lot of money in big pharma right now, and a lot of studies with huge numbers of patients on the use of these medications for weight, for diabetes, and they don't want to get involved in eating disorder research. what's that about? I'll leave you with that. Thank you, everyone.